cases. So would you bring up, please, the cases? And we start with the first case, FSHD, early onset spine deformity. So is Maike there? Yes. Yes. And of course, it's the FSHD Expert Center in Radboud, Nijmegen, right?
Yes, it is.
Please.
Okay, thank you. I don't know how much time do we have?
5 minutes.
5 minutes, okay. Well, I'm Maike Pelsma. I'm a pediatric physical therapist in the Radboud University Center. And I'm here together with a lot of colleagues and as well as Helma, our rehabilitation doctor. And we have a kind of a problem. With some children with FSHD, we see, well, you heard a lot of them, and of course you know them. But we also see, especially with the early onset children, we see a lot of hyperlordosis. And it's quite extreme, and they lose ambulation, well, mainly about the age of 15, and they often complain about a lot of pain and fatigue as well. This is like data from our natural history study, but I wanted to focus on the hyperlordosis. And this is a case of a boy, 15 years old, 14 years old, and he has a lot of pain. He's already non-ambulant, and he's doing some transfers with his dad or his mom. And here you see him sitting and also lying. On the right above, you see him lying with his leg as much as extended as possible. So you see a lot of hyperlordosis, and you see him sitting with forced traction because we wanted to see what was the amount of possibility we have, which mobility we still have. And on the other side, well, right in below, you see him with flexed hips, and then we don't have like the iliopsoas muscle, which is also affecting the above picture. So his length of the iliopsoas is also affected. Well, what we know, this is also from literature, is that we think that the lumbar hyperlordosis is like a compensatory mechanism because of the strength of the hamstrings and also the abdominal muscles and the gluteal muscles. So if you, because that's actually what we think maybe, and also there are 2 cases described in the literature which they have a spinal surgery. But if you perform the spinal surgery like you see in the right picture, then you don't have the compensatory movements anymore of the hyperlordosis for just be ambulate, to be able to stand. And this is like the literature. We see that there are only described 2 cases. On the left side, you see a girl of 16 years old, and you see her above, and the above pictures are before the surgery, and the other ones after. And here you see only the pictures, but she also improved her quality of life, and she had less pain, etc. And on the other side, you see also another person who is also really had good effects of the surgery. But we don't know what we have to do with our 3 children actually who have the same problem. So they have pain, and they also have progressive hyperlordosis. And we wanted to discuss this with you. So maybe you have experience with this and can, well, maybe we can have a talk then. Yeah. That's our problem. Yes.
Please take the microphone.
So we see similar hyperlordosis in LAMA2-related congenital muscular dystrophy, as well as in GDPS1-related congenital muscular dystrophy. And the main question is function, so your patient can support transfers, and you'd be worried that you might lose that. But another major issue is pain, but it seems the pain's going to the hip region. One One thought I have is we've had some patients with Lama 2 that have had a soft tissue release basically at the region of the hip, because hip flexion is, a contracture as well, and sometimes that may be helpful, but it's a center of gravity issue here, and so I don't know if that would help. It might throw things off, but I think the pain is a major issue, and if it is coming from the spine, the question would be, would a surgeon be comfortable, because the patient in the radiograph is it fixed to the pelvis? I think when you fix the pelvis, you're going to lose range of motion and may lose ability to do activities of daily living. It's a tough one. Yeah.
Yeah, it is. Yeah.
And what about the nature of pain in those? What is really is it a constant pain? So could you also consider other type of pain focuses? So could it be, well, if you look at all the bones of these, they are demineralization, so they have a type of osteoporosis as well. So could it also be a different type of pain in those?
Yeah, within that boy, we saw a lot of pain in his hip region, and we thought it was more about the compression up there, but we didn't know it that good.
No things on the spine to see, but
No.
the question goes further. What is happening with these kids that they grow like this? And when you understand that mechanism, then you maybe know also what's going to happen when you give them a spondylolisthesis, if you're going to lose ambulation, yes or no, and if you're going to do something about the pain. Yeah.
I think you have to use the microphone.
Yeah.
So this is the situation.
Well, we didn't reveal the mechanism, what's happening here, and we know a lot. Also, MRI data show us that paraspinal, the muscles are also weakening and also have more fatty infiltration. So that would be also the case, maybe. Sorry, you have one suggestion. Yeah.
Please take the mic. So unfortunately, the helpers are gone.
So a similar child with the hyperlordosis, before the pain started, actually, have you heard of a cash brace? So a sort of reverse of a cash brace in the lordotic area, but our child did not have pain. So we did this before she started developing pain. So she's not had pain, but she developed progressive scoliosis. We had to change her brace. I can show you pictures of that.
Okay, that's nice. Yeah, the two in the literature they also say about the orthesis that it's not going to work. That it's still progressive. Yes, but thanks. I wanted to look. Yeah.
Thank you. Thank
Yes,
you both.
thanks.
Yes. Of course. Well, you can do the applause. And then we have another case. So that's from Paris, from the Paris group. Is Tanya here or Teresina? No one here? They're all gone? Okay, so then it's a quick one. Sorry for this. And then we go for the next one. Is Vina there? Yeah. So please join me.
Good evening, everyone. I'm Dr. Veena from India. I'm a clinical geneticist. So here, this is a female child who is second live born to their consanguineously married first cousins. The baby lived for 2 years and 2 months of age. And as per you see the pedigree, there is a history of multiple and multi-level consanguinity, which is more common in India. So this couple came to me with 13 weeks of gestation of pregnancy, ongoing pregnancy, with the history of index child with a suspected muscle disorder and died with the muscle disorder. And only the DNA was stored. Unfortunately, no genetics was done. Coming to the antenatal history, it was a spontaneous conception. Only antenatal finding was oligohydramnios, which was detected at 26 weeks of gestation, and that continued. And coming to the birth history, it's a term female child with a birth weight of 2 kg, low birth weight, cried immediately after birth, and history of 7 days of NICU with low birth weight complaint. And the presentation was bilateral clawing of hands and inward placement of bilateral feet noticed around 3 months of age, and diagnosed with bilateral thalamus. And the parents also noticed paucity of all 4 limb movements, delayed motor milestones, and cognitively the baby was preserved. And there is also a history of recurrent episodes of bronchopneumonia. Coming to the examination. Okay, I'm sorry. I'm sorry. Coming to the examination, weakness of lower limbs was more than upper limbs and distal more than proximal. There was peripheral hypotonia and sluggish DTRs, and best achieved motor milestone was sitting without support. And if you can see the video, that's the only presentation with clawing of the hands. And as the workup done, the CPK was 195 IU per ml. Nerve conduction studies, absent CMAP and poorly formed SNAP, and suggestive of a severe bilateral upper and lower limb motor neuropathy. And muscle biopsy showed neurogenic atrophy, and nerve biopsy was not diagnostic. MRI brain was done, which was normal, 2D echo normal, ophthalmology normal, hearing assessment normal. So as the child was not there at the time of presentation of the couple with me, so with the history and the investigation, the differential diagnoses were SMA type 2, spinal muscular atrophy with respiratory distress type 1, SMART phenotype, and hereditary neuropathies and distal congenital myopathies were in my mind. So we have done a genetic evaluation. The SMA for MLPA was negative, and whole exome sequencing done, and family segregation analysis revealed the following. So there was a TTN gene which showed a variant of likely pathogenic and another variant of uncertain significance, which was accounting for congenital myopathy type 5 with cardiomyopathy, where the child didn't have any cardiomyopathy features, and it also accounted for limb girdle muscular dystrophy. And it was an autosomal recessive inheritance. So index child had 2 variants, and mother had only the VUS variant of the TTN gene, and father had the likely pathogenic variant. And also there were another genes found, that is PLEC plec gene. It's a variant of uncertain significance, which was accounting for limb girdle muscular dystrophy, autosomal recessive, which was present heterozygously in both index child and the mother, and father was not having the variant. This plec variant, now it is considered as likely pathogenic, now reclassified. And they also had a DMD variant of uncertain significance, which is an X-linked recessive disorder, which was present homozygous, being a female child in the index, and it was also present in the mother, and father had heterozygous DMD gene variant, but both mother and father were asymptomatic. So my discussion here is the TTN gene mutation, genotypically and phenotypical correlation. So the child presented as hereditary neuropathy more than the myopathy. So does this TTN gene correlate with the neuropathy? So I have come across some case reports and literature. So TTN gene is the largest gene, and its protein has a complex structure which is expressed not only in muscles but also in neurons. There is a recent paper which was posted in March 2024. It's a research paper by Ling George. It states that the TTN titin molecules are present in dorsal root ganglia in the embryonic stage itself. So this makes it possible for it to be associated with variable clinical presentations, and it plays a crucial role in muscle disorders as well as neuropathies. So do we have to consider it as a variant of uncertain significance? So phenotypically it is correlating. That was the question which I asked in the morning. So as per the genotype and phenotypic correlation, I think we have to consider this. So this was my other question, which is, should we offer a prenatal invasive testing for a VUS? So other phenotypes which can be present with the TTN gene phenotype are early onset severe limb girdle muscle dystrophy, and presenting findings are gait disturbance due to distal or proximal leg weakness, or nocturnal respiratory symptoms due to respiratory muscle weakness, and multiple phenotypes from fetal lethality, and may be associated with orthogryposis to non-progressive myopathy and dilated cardiomyopathy and rarely hypertrophic cardiomyopathy. So now my question is, what is the clinical implication of the DMD gene which was found homozygous and heterozygous in the father and the mother, and they are asymptomatic, and when we have seen the literature regarding the deleterious mutation testing, it is said to be damaging. So do we have to do anything in the parents like beforehand for the DMD?
Colleagues, what is your opinion on this? So she needs help. Marco, what about the Titin?
No, I have a couple of. Can you hear me?
Yeah.
So, did you exclude any other variant in homozygosity? How well covered is the exome or genome? Can you exclude any other things in homozygosity? What about the homozygous variants? Can you exclude other homozygous variants?
Sorry, I'm not getting your question.
Can you exclude any other homozygous variants?
Thank you.
Because the consanguinity
Because
in the
there
family.
is such a large consanguinity. Like,
There was no homozygous. Other than these genes, we didn't find any other variants.
but is it an exome or genome?
Ex-
Exome.
Yes, only in the whole exome sequencing. We didn't do a whole genome sequencing. It's
I mean,
only the exome sequencing, and copy number variations were done, which were normal.
I will not speculate on titin and expression in other tissue because, we have seen a lot of studies with ectopic expression titin, but then I will not go in that direction, honestly. But I will still go back to titin. And do you know if the second variant affects the splicing? Did you check that? Can you analyze the transcript? Do you have a muscle biopsy?
Muscle biopsy was done, sir, which was showing neurogenic atrophy of the muscle.
So I will do an RNA-seq for titin at least.
This was the muscle biopsy which was done, which showed neurogenic atrophy, and nerve biopsy was also done, which was not diagnostic.
Yeah, so I will do an RNA-seq on muscle. It works,
All muscle. Yes, I think that is the goal. And the DMD topic?
So whether we have to consider this TTN, titinopathy, being that deleterious that it could succumb the child at 2 years of life with a smart phenotype. And that too with one variant being a likely pathogenic and the other being a VUS.
Gina?
In my opinion, there's too many ifs with this case I would not do prenatal diagnosis for that, I don't think. And in terms of DMD, if the variant's present in the hemizygous state in an unaffected father, then that's just a benign variant that's common in that family, in that population, in my opinion.
So should I do familial segregation studies like another generation?
For the DMD gene?
Excuse me?
For DMD or for
Yeah,
type?
for the DMD.
I would just leave the DMD.
Not-
It's just a benign
But in the
variant.
mutant testing-
I wouldn't do anything more with the DMD variant.
Okay. But in the mutant testing, it was shown as a damaging effect. So should we have anything to be done in the parents? Like, should we do a dystrophin functionality or anything in the parents?
The CK in the father.
No, ma'am, we didn't do the CK. So should we do the CPK in the father first?
So that rules out.
Yeah, I would also step back and phenotype. I don't know if you know, is there any cognitive involvement in the proband?
No.
No. She's alert, normal
She's
language.
alert. 2D echo was done, which was normal, and the parents' 2D echo is also done, which is normal.
But I'm sorry, cognitive, mental, any
Okay.
developmental,
Cognitively preserved, only motor delayed development.
only motor delay. Okay, thank you.
It's a girl, sir.
With the missense, in the cases we don't have cardiomyopathy with truncation plus missense at that age.
So
at
this was
least.
the
So
only
that would
report
fit.
which I have. they didn't test for the dystrophin because the CPK in the child was only 195. So they didn't expect DMD to be the first diagnosis. Yeah. But the child is no more, sir. So with the slide, should I get it?
But I still wonder, why is it a myopathy?
Yeah,
You
sir,
have a,
that is another.
neuropathy and you are searching for mutations in genes that produce myopathy. Could it be an acquired neuropathy or another? I don't know. What are the mutations for the genes that produce neuropathy?
That was my first question, sir, that whether it is genotypically and phenotypically correlated. So as per the TTA gene, it is also associated with neuropathies and myopathies, is what the literature says, that it can be presented as polyneuropathy. No.
So you see the disagreement.
Yeah, that's
Unfortunately, we need to leave that case open.
okay.
Final comment.
Yeah, final comment. Did you look for a more complex syndrome? Look for the larger deletions in the chromosomes because maybe they.
The copy number microarray was done, which was normal. So.
But I think this is the case. It's a more complex.
So now the mother is
syndrome.
pregnant and she doesn't want the other child to suffer with the same condition. So now I am helpless with the prenatal invasive testing, given the variants are of uncertain significance and they are not correlating totally with the phenotype of the child, and the DMD, which is alarming, but probably I will do a CPK in the parents.
I mean, as a last resort, you could maybe do whole genome in the proband and look for homozygous non-coding variants that alter splicing in a gene compatible with that phenotype. That's probably something that would be worth doing. I think if you find a homozygous variant in a gene that fits a congenital neuropathy, then that would be a diagnosis. So you may just have missed it on the exome, and all of this is a red herring.
Which intronic mutations which I miss, I can be covered in the whole genomic is what.
Yeah.
Okay, thank you.
Especially if they're pregnant. Yeah, if
Thank
you can
you.
do that quickly.
All right, so we can't solve. Jochen, it's your turn. We have 3 more, and then you are good for dinner.
Yeah, thank you. I would like to present a patient where I would also be grateful for some help. It's a bit of a complicated history. The patient is now 52 years old. She presented at the age of 45 at the first time. She had hysterectomy at the time and developed thoracic pain and an increase of creatine kinase. It was suspected to be either pleurisy or perimyocarditis. MRI, cardiac MRI was normal. And at the time she only had myalgia, but really no weakness. The rheumatologist thought at the time, because of abnormal antinuclear antibodies and highly elevated Rho and La antibodies, that it might be Sjögren's syndrome, but the clinical signs didn't really fit to that. She did, however, have on the MRI, muscle MRI, some edematous changes, and therefore the provisional diagnosis of Sjögren's syndrome with concomitant myositis was made, and she was started on hydroxychloroquine. A few months later, she then came to us with persistent muscle pain, but again, no strength, no atrophies. The CK was still elevated. There was no spontaneous activity on the EMG, and the muscle MRI didn't show any edematous changes. And therefore, we decided to sort of follow a watch and wait strategy first. And she was fine for another 3 years. And in May 2020, she then presented with rapidly progressive respiratory failure, even required artificial ventilation. The rheumatologist saw her again then and suspected some type of connective tissue disease and commenced her on methotrexate and continued the hydroxychloroquine. But she again deteriorated, came to us a few months later, and then showed weakness of her trunk muscles and limb girdle muscles. Her walking distance had become very low. Her past history and family history were not really very remarkable, and I'll show you in a minute the video of the patient with the examination findings. She had some mild facial weakness, some truncal and shoulder girdle weakness, and atrophy of the trunk and limb girdle muscles, and it was a phenotype with sort of reminiscent a bit of facioscapulohumeral muscular dystrophy. And you see here the patient walking. She's sort of very thin, hyperlordotic gait, sort of proximal limb girdle type. She can't stand on her heels really well, can stand quite well on her tiptoes, sort of fitting with FSHD type picture. She can't get her arms above the horizontal. You can see the deltoids are quite well preserved, whilst the biceps is atrophic. She's got very severe truncal atrophy, paravertebral atrophy, winging scapulae on both sides. And yeah, this is just to show that there is also some atrophy of the pectoral muscles, again, a bit in keeping with facioscapulohumeral dystrophy, and some mild facial weakness when she sort of closes her eyes maximally. No. Right. The laboratory findings were as shown in here: mild creatine kinase elevation, troponin T was elevated about tenfold, but there was also a bit of systemic inflammation. Blood gases showed some compensated chronic hypercapnia. We did some further autoantibodies, and again, the antinuclear antibodies were very high. The Sjögren-specific antibodies were very high. Other myositis-associated antibodies were negative. Only the MUP44, which is quite non-specific, were positive. Muscle biopsy was done, which I'll show you in a second. It showed chronic myositis, no vacuoles, regular structure of the myofibrils, and it was recently followed up again by Professor Schoser, and in particular with the question whether there might be any Nemaline bodies, but it actually wasn't the case. And it was compatible with FSHD, the biopsy. This is the biopsy. Some inflammatory infiltrates, CD4 and CD8. Additional findings, neurophysiology didn't really help very much. EMGs just showed myopathic pattern without spontaneous activity. The MRI, some fatty infiltration, and the lung function, severe restrictive pattern with normal structure of the lungs, lung parenchyma, so clearly a muscular weakness. Because respiratory failure is very, very rare in Sjögren syndrome, we did some molecular studies, and first the gene panel for limb-girdle muscular dystrophies, also other genes which might be involved in the truncal weakness, but they were all negative. The thing which was positive, however, was pathological restriction digest. There was a deletion on 4q35 at the FSHD locus. But this was a bit difficult to interpret because the digest of the other enzymes didn't really fit with the deletion at 4q35. And therefore, it was finally thought that it was a translocation of some type of unclear significance. So how did it all continue then? The patient continued on methotrexate and chloroquine, got even worse. Now she's only able to walk about 10 meters at maximum, is almost wheelchair bound. The laboratory results were very similar, nothing new, and again, no interstitial lung disease. The ENT people couldn't find any clinical symptoms which would be in keeping with Sjögren's, and therefore the question was, is it secondary Sjögren's with overlap myositis, or is it FSHD with inflammatory changes, and what should we do? And finally, now last year and this year, we then continued on some molecular studies regarding the FSHD. We looked at the mother. She was normal, no FSHD carrier. Optical genome mapping was performed, which then confirmed the deletion on a permissive haplotype, and sort of FSHD1 was then confirmed on optical genome mapping, and methylation studies, which was the most recent thing, however, showed normal methylation in DUX4 and D4Z4 repeat. And so finally, from the methylation studies, FSHD was then excluded. So the question now remains for us, is it overlap myositis, or is it FSHD with inflammatory changes? For both of these differential diagnoses, the very rapid deterioration of the respiratory function would be unusual, and in Sjögren's syndrome, it's actually only never been described, and only in 0.6% of cases there is actually overlap myositis. So the big problem for us is now what to do. Do we try other types of immunosuppression? Do we give IVIG? Do we no immunosuppression at all? Or is the diagnosis maybe altogether wrong? So I'll be very interesting about your views on this.
I have some questions because the phenotype resembles very much Pompe disease. The question is, you have done the panel, the NGS. Did you exclude the lesions? Do you have a DVS for enzymatic activity of maltase, acid maltase?
For Pompe's?
For Pompe's disease?
It was included in the exome, yes, but there was nothing on the biopsy.
Yes, yeah, but that's NGS. If you have a large deletion or something like that, you are not seeing that.
But the biopsy didn't show anything.
No, the biopsy could be normal even.
But in a patient who is so severely affected like her.
To me, at least, I don't know, I'm not a geneticist, but I believe that there is still space for excluding better Pompe disease, for example, because the respiratory compromise, the clinical phenotypes, the age of is pretty much suggestive.
What did MHC1 and MHC2 showed in your biopsy?
I can't remember, actually, I must admit. I have to look it up again.
Now, this lady has also been treated with chloroquine for quite a while. Is there any evidence that she might have a chloroquine myopathy?
No, the biopsy was done only a short time after the commencing the chloroquine treatment. So it was only a few months, or 2 or 3 months after that. So we didn't think it was the chloroquine. And there were no vacuoles or anything to see either.
I think everyone recognizes what he or she knows, and I recognize sporadic late onset Nemelin myopathy, and that's why I think you looked at the biopsy. But was this biopsy taken early in the disease course?
That's right.
There was no second biopsy.
No.
Well, I think that's something to consider, because the cases we've seen with sporadic late onset Nemelin myopathy with gammopathy, in most of them, the first biopsy was negative for Nemelin rods, and then we repeated the biopsy, and eventually rods appeared. But since you have an M protein, that is something to consider, I think, to repeat a biopsy from a moderately affected muscle.
Yes, I would also exclude FSHD for the MRI pattern, that it is more typical in this condition, and she had no typical signature. And did you test also VCP in your genetic panel?
Yes,
It was negative.
And I have a question following the the sporadic late onset Nemaline myopathy. We currently have 2 patients. One is 27 and one is in her early 40s. The phenotype is quite similar, but we have ongoing discussion with our hematology colleagues because both do not respond to steroids, do not respond to IVIGs. There are some literature reports on the stem cell, whatever it is. Transplantation. And they are close to supporting our view in the 27-year-old, but say that monoclonal gammopathy in 50s, this is not really argument for something that may not really be effective. So what would be your view?
Well, the clue is, we should take that up. So I still believe also that this is an Nemaline myopathy, an acquired one, and we should go for a second biopsy. This is still the best guess because the combination with Thurgrin is described in the literature. There's something ongoing in this direction. But I have a question for our genetic folks here. So we have this positive optical genomic mapping, but a normal methylation. So is FSHD1 completely out? So what is the real true test, or do we need to go for Southern blotting?
Well, she had the Southern blotting, which...
Did she have?
Yeah, I think a negative methylation status probably rules out FSHD. Is that,
Yes.
Nicole, that's the consensus, right?
Yeah.
That we would exclude it based on the methylation.
Yes.
And that in 1% of cases, Bionano gets it wrong. Something like that.
I was trained by Richard Lemmers by all the cases we've discussed, but he's coming to the meeting, so I would find him. Richard Lemmers from Leiden. He will be here tomorrow, so you should talk to him to make sure.
Okay, thank you, Jochen. So we are still
So we'll do a biopsy again.
working up this case. Thank you for this very nice one. Okay. But I see your alertness coming back, so they're nearly ready for the dinner. But we have 2 more cases of one of the next chairs of the teaching course for next year. So Jorge will, well, if you make the one short, we can have the second one as well, because the second one fits so well for dinner.
So I'm gonna hurry up then.
Yes.
So, hello everyone. After a very long myologic day, I have to present these 2 cases. The first one is, I'm Jorge Bevilacqua in any case, is from this lady. It's a 40-year-old woman, a little overweight. And she came to me because she had a brother that was already diagnosed with dysphalinopathy. And after delivering the first child, she started experiencing weakness with a CK of 6,000, myopathy that was clinically evident, the brother with the dysphalinopathy confirmed, and all the parameters, electromyography was myogenic, so no special thing there. The testing showed the distribution of the weakness, that it was compatible with diagnosis of dysphalinopathy, and she wanted to confirm the diagnosis. There are some videos here for you to show to appreciate the still mild weakness. I'm gonna go faster. You see. So there's nothing special up there. And the question was how we will continue the study, which is pretty obvious. What would you do? What happened? Nothing. We leave it there. Well, we did a genetic test, just a panel. But the curiosity, it doesn't come from the dysphalanopathy. The curiosity comes from, she had a pathogenic mutation for dysphalin, a likely pathogenic one, which confirms the diagnosis, but also she has a pathogenic mutation in a dominant gene that is desmin. So the question is she having the weakness from the dysphalanopathy or the desminopathy? We will have a double hit myopathy here. Until now, as you can appreciate in the MRI, the involvement is more or less typical for a dysphalanopathy. At least I would have expected, I don't know, the semitendinous fatty replacement in the ischiotibial muscles, thinking on the desminopathy. She has no cardiac involvement so far, but it's not a case of problem in the diagnosis. It's just a curiosity to see how it goes on. If you have any idea of what to do at this stage, should we pursue a biopsy to see expression of different proteins, or you should wait and monitor cardiac function, for example, which in dysphalanopathies is always mainly respected, but it's not in desminopathy. So that's the idea of having this little discussion with this case. I don't know if you have any thoughts to share.
Let's vote.
Vote what?
So first of all, do we need a follow-up, a cardiological follow-up? Who is in favor of this cardiological follow-up every 6 months?
Everybody.
Once
all right.
a year.
I don't know, Karim, what do you think? What would you do? Mike?
Over lifetime, the penetrance of cardiac involvement in patients with desminopathy is probably almost 100%. But sometimes neuromuscular manifestations can precede cardiac involvement. And so in some patients, you have myopathy and cardiac involvement occurs years later.
What about a cardiac MRI?
It should be the most sensitive you can to diagnose cardiac abnormalities. Holter ECG, cardiac MRI can improve the sensitivity of the diagnosis.
Sure. For the geneticists.
Jorge, what about the brother, the desmin in the brother? Did you check desmin in the brother? In her brother?
No. As far as I know, it's done in Argentina. I don't have the genetic
I would be
testing.
curious to compare then the phenotypes if there is, and then the parents
That
to see
could be.
dysphalin.
Well, clinically, she behaves until now as a dysphalanopathy, and she's 40-something, so desminopathy sometimes starts with the symptoms later. And the problem is that it's overlapped. I don't know. Perhaps in 5 years, I can tell you how it goes and whether if the desmin gene expresses or not as in the pathology. But I would follow up the heart anyway. Go on.
What we were discussing is that in this case, we would probably only have tested the dysferlin gene for the mutations in the brother and not do a panel in a case like
That's
this.
the point. I believe they have only the dysferlin gene tested in the brother, right?
No, I mean, but once the brother was diagnosed and then she came, I would have tested dysferlin for the same mutations as the brother and not do a panel. And you
All
would not
right,
have
no,
ended with
that's, it's a logistic problem. It was easier to us to do the panel, the complete one. So, but that's
problems.
interesting. We have more information. We probably have a phenotype in the brother and the sister that she may become more severe, and otherwise we will be thinking that dysphalanopathy is quite variable. But with more information, perhaps there is a double hit.
Isn't it often customary that you do a biopsy if you have uncertain genetic data?
Yeah.
Why don't you do a biopsy?
Well, because it seems not to be necessary now, but that's why there, second one, we could do it, and to see what is over there.
Okay,
If there is a myofibula.
Next voting. Who would
Voting,
go for
biopsy or
biopsy?
no biopsy?
Biopsy.
Oh, la. So more work for me then. Well, next year I tell you
Cardiac
the
MRI,
continuation.
Yearly follow-up, and we
the
will
parents,
Right.
result next year.
And the parents,
Okay.
Desmond is a dominant one. Had the parents any cardiopathy?
No, as far as we know.
Because this
Yeah,
could
yeah,
be
you are completely
another
right.
point if the parents had
Segregation of the
segregation
two
of
mutations,
Desmin- of
actually.
Desmin.
Yeah, absolutely. And she has a daughter that is a child at the moment, so, okay. Next one. This is a very interesting one, actually. And I know that Teresina will be happy with this case. I'm gonna do it quickly. This is a lady that at the end of the year 19, in 2019, she was quite happy, celebrating with the family, and few days later, she started with kind of lumbago, polyarthralgia, and myalgia syndrome. It was no evident cause. Fever. She started with dry cough, headache, nausea, vomiting, with we may say, an inflammatory, probably infectious syndrome. 3 days of self-limited diarrhea. And she it was thought that because she has an antecedent of pyelonephritis, that it was pyelonephritis, so she hadn't studied in that direction. That didn't show the pyelonephritis, only some nephrolithiasis, and she started with antibiotics and symptomatic treatment. And one day later, she started with generalized erythema that was thought to be consequence of the antibiotic, but developed a facial edema, chemosis, yes, swelling of the conjunctiva, and a kind of mild respiratory involvement, and then evolved to a generalized weakness, and more than weakness, I would say a kind of edema and stiffness of the muscles in general. She was like, sorry for the expression, but it was the impression of a sausage. She was edematized and couldn't move, and everything was packed. No, she's laughing at the end, but that's a very descriptive thing. And she was in pain permanently. I know that because I took the biopsy and I saw her. And started developing some kind of weakness. What I would like to represent is that it was a weakness with pain and swelling, so those kind of weaknesses that you don't know if there is a functional impotence because of pain or real weakness. So she went to the emergency room, and this is the report. She was sleepy but oriented, and she has facies that was symmetrical. You have the picture here in December, and that was a few days later. And well, as I say, generalized muscle tenderness with this proximal weakness, the reflexes were present. No other neurological, meaning central nervous system signs, and description of the weakness, and all the other parameters were more or less preserved. So up to there, I would think everybody agrees that first possibility is a kind of any inflammatory myopathy behind this patient. Anyone thinks differently? Would you go for something different than an inflammatory myopathy to be checked and tested and excluded? No? It comes there. CK was 1400, about. High, clearly high, not as high as we are used to be in inflammatory myopathies. There are some, I won't say that because it's too guiding too much the diagnosis, but there are some parameters that are not normal here. Well, there was an inflammatory syndrome. CK was high. The transaminases, not so much, right? higher, but little. Eosinophilia is a clue here, right? 8% eosinophils in blood. And anyways, it was thought that was inflammatory myopathy, so they run a panel of myositis that was negative. The electromyography showed a myopathic pattern, and there was a myocarditis. Again with Karim, right? It goes to the heart, and with no obvious explanation there, but somehow it comes together with an inflammatory myopathy. It could be a rheumatic disease, something like this. But honestly, we didn't have a clue of what she had because it was not proper dermatomyositis or a proper or typical inflammatory myopathy. And well, what to do next?
So I think a good guess at the beginning was MDA5 antibody, because you have the edema and things like that. That would fit very well to the clinical.
But she had no proper erythema on the other side.
Yeah, you don't need
no.
that. So
I agree.
The edema is really something that is, also with them.
No, there was a pericarditis.
It was negative, so it's out.
Yes.
Any good idea? And it's related to dinner.
When you mentioned a special kind of stiffness, could it be a xenophilic fasciitis, fascia involved, not the muscle itself?
So Schulman syndrome, you think in this direction? So that would be a rheumatology.
It's something that should be considered. Yes, why not? It is inflammatory as a syndrome.
So the diagnosis is already known?
Yes, and you will like it.
You don't know it. You won't like it because it's.
No, he will like it.
Yeah, he might like it.
Right, what would you do next?
It could be trichinosis.
Why? I don't know. Tell me why. I don't know. They're talking about rheumatic disease.
Yes, Whipple disease is good.
Whipple disease could be. We don't have much Whipple disease in Chile.
There was a note of eosinophilia in the beginning, so I believe parasitic infestation should be considered in this situation.
Yeah, also. I like the hypothesis of the trichinosis, but is there any clue in the clinical findings and the ancillary testing I am showing to you that goes in that direction?
Well, you didn't tell us anything about the eating habits of this woman.
All right, but that's something that doctors never asked. She was celebrating the end of the year with some pork that was brought from the countryside with no sanitation, not properly sanitized. But that's a question that nobody did during a month while she was hospitalized, right? The other clue is the eosinophilia, which is, it comes along with a parasitosis. But the surprise was when we did the biopsy and we saw this, I don't know, doctor, if you would like to describe the biopsy, Professor Gebel? Yes. Right.
The rest I can't see.
Right, and what about this?
In the middle of this right picture.
Okay, I'm going to take the right picture right now. What about that? I don't like those eyes looking at me, right? And those other down there, right?
They still might move.
Yes, those are the cells that nurse the parasite. And when you see that in more detail, you see that, which are the larvae in the middle of the biopsy. So that's a trichinosis. That is a diagnosis that is, as Professor Gebel says, asking better. And as Nicole said earlier on, 90% of the diagnosis is even in the questioning of the patient and the clinic. So a couple of more questions. It will be just serology for trichinosis antibodies. Diagnosis will be made, and we could avoid the biopsy. That's why you don't see trichinosis much, because the diagnosis is not done with biopsies, done with serology, and then the patient gets and it was in neuromuscular disorders actually, the patient get the proper treatment with albendazole and she recovered completely, but it's a matter of interrogation actually, you may say, and some bits of the clinical findings. Nicole?
A short question, because
Yeah.
I don't see this at all, or I don't ask sufficiently, but the pyelonephritis, was it also related?
No, it was a misinterpretation of the fever and the context, and she had this previous episode, so they thought then they thought on diarrhea. When I say they, is people on the emergency room, but everybody was lost. When we saw the biopsy, we say, wow, but nobody, because we don't see that neither, but it's much more common that we know there is a pandemic zoonosis actually, even here in Europe. But the point is, you don't do biopsy. I hope in the dinner we don't have pork. And if it is, not coming from the countryside, right?
We don't know. Thanks so much. Thanks so much, Org. So I think this was an absolutely fantastic end for this very, very long day. And thanks all of you so much for staying here alive and having even a final good discussion here. And of course, all the speakers, thanks a lot for all your work and work up of these cases and things like that.